dislocation 3 weeks PTA. On 1 month PTA, she had a motorcycle accident, like the dog passing by her motorcycle and she fell on the right side, and then her knee became deformed and she cannot walk and was taken to the hospital. At the hospital, she got reduction of the knee, and
This is the emergency, a picture at the emergency room, right?
yeah.
Yeah. So please describe the deformities. Show one.
So the deformity, you can see asymmetry between the two legs.
Yeah.
The knee is internally rotated,
Yeah.
and like I'm not sure if this is the patella. I'm not sure if this lump is the
Yeah.
prominent patella.
Uh-huh.
There's no sign of ecchymal. Maybe there's some ecchymosis over here.
It's too early to have ecchymosis. It's just few hours, right?
So no sign of other inflammation yet.
How about the alignment of the knee joint?
I feel like it's internally rotated.
Mm-hmm. It's valgus, right?
Yeah.
This is valgus. The patient that had a history of accident and deformed, what are two common deformities or two common diagnoses for these kind of patients? Two common. Knee dislocation, another one? The kneecap or patella dislocation, right? But you can see the alignment. So you see that the alignment is so much deformed, like this patient. Okay, the knee is like severe valgus, right? That is the knee dislocation or tibial femoral dislocation. But for the kneecap dislocation, you can see that the tibia and femur is in a good alignment, just the kneecap deformed, right? So sometimes the patient cannot tell you exactly what is the difference between these two conditions. Okay. But if you have the pictures like this is the pictures from her telephone. So that's good for us because nowadays everyone have the smartphone, right? They took the pictures, and this is quite important information. Right? So for these deformities, what's your name? Akawat. Akawat, right? Akawat. So, what do you think? What is the structures that can be injured?
So if it's like a valgus deformity, I think obviously you should have like at least like injury to the MCL.
Yeah, the medial side, right? Because the valgus, so the medial side was stretched, so the medial side should be gone. Okay? And also, if the knee deformed a lot, all the ligament in the knees can be torn, right? This can be 2, 3, 4 ligament. So actually, there's someone that classify this kind of injury, okay, from the numbers of ligament. So you have like 2 ligaments, okay, KD2, okay, 3 ligament, KD3, 4 ligament, I mean, medial lateral ACL, PCL, we call KD4, okay? And the KD5 is the torn of the ligament, 4 ligament together with the fracture, okay, or fracture dislocation. Okay. Please read the film. Cha-cha.
The X-ray of the film of the right knee, and there's a knee dislocation where there's lateral displacement of the tibia and also the patella, and there seems to be, I don't think we see any fracture of the root.
So you cannot see the obvious fracture, right? Okay. So this is the medial lateral dislocations. No. From this view.
From this view, so the medial lateral.
Lateral. Okay. So lateral view, the deformity is not too much. is still in align. Okay, so this is like displacement in coronal, but in sagittal it's not displaced this way. Okay, but if you have the lateral and displaced anterior and posteriorly, you have higher chance of what structures? And what structure is in the back? Popliteal artery. Yeah, popliteal artery. You have higher chance of popliteal artery because if it displaced in this way, okay, the vascular will be stretched and it can be torn. Okay, but this is like rotational this way. Dislocation like this. You know, in sagittal it's not moving that much. It's like this. Okay, you can see obvious deformity, but in lateral view it look not too bad. So vascular injury. That's why this patient have no vascular injury. Even she has a very gross, obvious deformity at the beginning. Okay. So if you're the first doctor at the emergency room, what will you do?
So firstly, for physical examination, we test for like neurovascular injury first, and then reduce it back.
What is the neurovascular injury that you test? Give us your practical point.
So a palpate,
What will you do?
Behind the knee to see whether the popliteal artery is like intact or not, and also looking for the sensory.
Actually, that's not easy. And you don't need to do that because the knee is still deformed. Okay, it's not easy to palpate. So the practical point is that you don't need to palpate this, but you need to palpate the distal part. Okay, two artery that you need to palpate. What is that?
Dorsalis pedis and also the posterior tibial artery.
Okay, which one is more important? The point.
I think it's dorsally pedis.
Dorsalis pedis.
More distal.
You want to change your mind?
Posterior tibial changes like the branch of popliteal artery.
The posterior tibial artery behind the medial malleolus, right? This is major vascular of the foot. So you should palpate the posterior tibial artery. But actually you need to palpate both, right? Sensory also, right? And check whether the patient has foot drop or not. Okay? So this patient have good nerve, she has no foot drop. So in valgus injury, rarely the patient have foot drop. But in varus injury, let's say the patient have deformity like this, okay? But this patient have deformity like this, right? The valgus. So the nerve is not under tension, okay? But if the patient have deformity like this, like the medial dislocation, right? You may have the higher chance of the peroneal nerve injury because the nerve will be under tension. So this patient, the foot is okay. หนูกระดกข้อเท้าดิครับ Okay, it's okay. She can do dorsiflexion. ไม่ชาใช่ไหมลูกไม่ชา So first thing you do to palpate, okay, and document. Don't forget to document because some patients they have injury of their vessels, okay, and you didn't document at the beginning. And after reduction or after procedures, the patient have vascular problem. But if you didn't note, if you didn't take the note at the beginning, yeah, it's your fault. Okay, the patient may blame that. This is because of you did some procedures and make the vascular disruption or problem after that. Okay, so keep in mind. So after that, after you check everything document, what is the next step? Chichano? What is the next step? Examination, X-ray, and then?
See if the patient can do close reduction or not.
Close reduction. Yeah, because now they have the gross deformity. But not every patient came to see you like this. You know, many, or I say more than half of the patients was already reduced at the scene. because you know if she had dislocation like this, so we call the ambulance, right? Or sometimes Rum Katanyu or Tektung, right? So they came and helped the patient do some first aid because the deformity before they transfer their tract, and then it was easily reduced. And the patient came to see you at the emergency room like nothing, like soft tissue injury. Right? But if you don't suspect or you don't keep in mind, you may miss this condition and let the patient go home because the deformity is gone already. It looks like nothing. Okay. So keep in mind, what is the hint that will tell you that this patient is not normal?
Pain.
Huh?
Pain.
Pain. What else?
Instability and mechanism of injury. So you can ask like whether there was deformity at the scene.
Yeah, that's important. You need to ask that. The patient is conscious, right? You can ask that, is there any deformity at the scene? So you say yes, and the first someone has already reduced. Okay.
Symmetry compared to the other side. Maybe there could be like underlying pathology that's more than just like a soft tissue injury.
Okay, the swelling, right? But you know the swelling comparing to the ACL is less. Why? Not Visha, not Tisha. Why? Not Tisha. Why? Swollen or ballotment may be negative because the fluid extra was set because the torn capsule. Okay, understand? So what's the hint?
There's a remaining neurovascular defect.
Yeah, remaining neurovascular problem. There you have the asymmetrical pulse, or you have foot drop. Okay, you can say that you should suspect is it if you have the distal neurovascular problem. What else?
You can check for the range of motion, like whether she can bend the knee or not.
Yeah, she will be limited by pain and she cannot move. What else?
Do ABI and
ABI. Okay. What else?
There will be like signs of ligament being torn, like the anterior or posterior vertex. Positive.
You should do that or you should not do that.
But if you do that, you run the risk of having the knee dislocated.
Yeah. So you do this, right? Test the stability. So we not recommend you to do that. Why?
But you could dislocate the knee again and also damage.
Yeah, you do more harm, right? And the patient with so much pain. So what I recommend you to do is that, okay, you can slowly lift up the leg like this, okay? Because sometimes you need to clean, right? You need to do some dressing. So the hint is that when you lift the leg up this way, the knee will be like hyperextension, or we call the genuinely curvatum, right? This is quite common because most of the time the capsule is torn, the PCL is torn. When so we lift the knee this way, it will be like hyperextension. Okay, this is very simple. And also when you test the knee in this zero positions and you do some valgus, you can see that the patient has severe valgus and valgus deformities. So just observe that the patient have hyperextension or not, or the patient have these severe valgus deformities or not. Okay, good. So now, this is about 4 weeks after the injury. The patient was reduced at the emergency room and immobilized shoulder frames in cast. Okay. So, Mr. Your turn again. Chong Kwan.
from the film.
Is that appropriate? It's good or not?
It's a good reduction. The joint space is now symmetrical.
Yeah.
And the alignment is back to anatomical
Mhm.
position.
Yeah.
And from before we didn't have this film, but if we did, we could see that I'm not sure if there was misalignment before, but now it's all aligned. And the patella is in its anatomical position.
Yeah. So on the film is look good, right? Okay. And back to the films. So I recommend you to not put the cast on. You should put the the slab, right? Because why we not recommend you to put the cast on? Huh? Yeah, right. Because if you put the cast on, sometimes there's too much pressure. Because sometimes it's much swollen. They have the compartment syndrome or the risk of vascular injury. Okay, so put the slab on, but make sure that the joint space is equal. Make sure that the alignment is good in both plane, in this plane, okay, and also in this plane also, right? There should be no subluxation. And we recommend you to put the cast on in which degree? 0, 30, 90 degree.
20 to 30 degree of flexion.
Of friction? Yeah, that's a wrong concept. Yeah, many doctors, even in the book, yeah, they wrote that 30 degree, 20 degree, that's wrong for the knee dislocation. Nowadays, there's proof that you need to put it in 0 degree, okay? Because in 0 degree, you make sure that the knee is not sagging. If you have torn PCL and put the knee in flexion, what will happen when the slab loose? What will happen? The knee will sag by gravity. Okay, and this would happen. This would happen. I can show you later. There are a lot of cases refer to me because they put the cast on or the slab on in 30 or 40 degree of flexions. When it's getting loose, the knee will subluxate in the cast, and out. Sometimes they delay to me very late, like 2 months after the injury. So it's difficult to reconstruct or to repair everything back because now the knee persistent subluxations inside the cast or in the slab. Okay? So keep in mind 0 degree. Okay? And make sure that the medial lateral joint space equal. And in sagittal plane, it should be like 0 degree. Okay? So this is good because even she put the slab in, I think 10 degree or yeah, but the alignment of the knee is okay. Okay, it's no subluxation. You, the medical students, or you, after this you'll be the general practitioner, right? So the first thing is that when you have this kind, you need to admit the patient in the hospital. Okay, admit the patients for at least
3 days
3 days. For what?
to see whether there are neurovascular injury or any complication like compartment syndrome.
So Shasha, if the patient have good pulse and good ABI at the beginning, will you admit the patient?
So you need to admit the patient.
Why?
Because there could be like a thrombosis of the artery from the intimal tear from the artery.
Yeah, even the patient have good distal vascular, you need to admit the patient to observe at least
For at least
3 days, 48 to 32 hours, okay, to observe the late thrombosis, or we call the propagating clot thrombosis. Okay, after that, okay, and we will not do any procedures before 3 days. Okay, because if you jump in and do some procedures, and after the surgery the patient have the vascular disruption, okay, or vascular compromise, they will blame you. That's because of you. Okay, try not to do that. Okay, what is the heart sign? Yeah, yeah, powerlessness, right? Pulsating or expanding hematoma. Yeah. Yeah, bruised. Yeah, something like that. Okay, so your heart sign, you need to admit the patient and consult the vascular surgeon. They need to jump in and do some procedure of bypass right away. Right. So what's the golden period?
6 hours.
6 hours, right? If you delay more than that, what is the amputation rate?
80%.
80%. Yeah, very high, 81%. Okay. So we need to jump in right away, consult the vascular surgeon. So this patient, I think she's okay, she's safe, okay, she's no problem about the vascular. And now it's 4 weeks, 4 weeks already she's referred to us. So what's the next step?
So we need to investigate if there is any ligament being torn or not.
Yeah,
So that
okay,
we may have to repair it.
yeah. So the best investigation nowadays,
Maybe MRI.
MRI, okay. Sister, MRI on the อันนี้กี่วันหลังจากบาดเจ็บคะ MRI เนี่ย
4 วันจ้ะ
Uh-huh. 4 วันใช่ไหมครับMRI the beginning is good because you can see hematoma you can see that this is MCL right this is the meniscus you can see this avulge okay. Okay the medial side was torn this was torn okay you can see this is MCL and you see the femoral attachment is torn this is important because when you get in you know that the pathology is on the medial side and this proximal okay, okay. On the lateral side you can see this LCL okay not too bad and this is probably this lateral meniscus not too bad okay this is probably this tendon okay this is lateral meniscus from this view it's not too bad and this is sagittal view you want to see the ACL and PCL right the meniscus is in good shape triangular shape okay this is the PCL attachment at the tibia okay you see that it's buckling it should be here so PCL is complete torn right torn this is ACL you can see that ACL is torn from the tibial side okay at the femoral attachment is okay see so this is ACL I think ACL is torn from the tibial side okay
the examination specifically to the ligament so I think first you suspect the MCL test so I think a Walker's test is necessary so generally
at 0 degree
and also 30 degree as well
yeah.
so
first we do for doing that you do the inspection first
relatively to the valgus position and also there were like mild swelling of the knee but there were no like erythema or ecchymosis then and also inspection palpation to see whether there are any like ballonment sign positive or not
you see both sides not equal right you still have some swollen okay the alignment is not too bad leg length equal เกร็งขาสิคะลูกเกร็งขาแข็งokay good so slightly valgus and also swollen right you can see some abrasion here okay our next step
so palpation generally palpation along the knee joint to see whether the patient is like tender or not so เจ็บไหมครับอันนี้เจ็บไหมand also palpate on the patella to see whether there are any like fracture or not and also did the Lagman Test to see whether there is any effusion behind the knee so in this patient there are no like effusion behind the knee joint so after palpation you become maybe like ask your patient to like flex her knee to see whether there is any like limitation of movement or not ให้ลองงอเข่าได้ไหมครับงอเข่าไม่ค่อยได้
motions
so after passive motion you may like do active motion เดี๋ยวหมอ
yeah not aggressive not invasive to the patient starting at 0 degree 30 90 and then the aggressive test like pivot shift or maxillary test that is the last so non-invasive first okay if the patient's good just no pain we can do like pivot shift or maxillary finally okay? but this patient we cannot because she is limit motion right and also still have pain so what we can do is that you just check the alignment at 0 degree right now make sure that the patient can go ไปได้ไหมครับสูงไหมลูก slightly flexion okay slightly flexion because she's immobilized in the slab yeah? and also you check the stability at 0 degree you can see that The valgus positive, right? Valgus, okay, it's okay. At 0 degree. And then go to 30 degree. Okay, check again the valgus. You see that valgus is small. Okay, you still have the valgus stress positive, but the valgus is okay. Yeah. 30 degree also. Okay, and at 30 degree you can check her ligament. เอาไป request ให้หน่อย so Lagman test positive. So that what you can do now, okay? Because you cannot bend to 90, you cannot do the posterior draw, anterior draw.
So we analyze stresses. So in 30 degree.
Just sit down. That's it. So the way to do at 30 degree, you just put your hands on the popliteal fossa like that, okay? Like that, okay? And shift this way. See? Okay, this is Lagman test. Show me again.
ก็ดีกว่าหมอขาว
That's maximum. You feel? Some sagittal instead of lateral side is like hinge on the lateral side, okay? Like this. This is valgus, okay? Out and in. You can feel that. You can go more. This is valgus. You start at 0 first and then 30 degree. Okay? Okay? Lagman test. This way. Like this. Like this. Grabs. Maybe it's not too easy. Okay? Atisha. Yes, right. So this stabilize. Right? This should not move. You just move the distal part, okay? That's good. Yeah, that's right. That's right. Okay? Is better?
Yeah. That's right.
Very good. Huh? You can feel?
Yeah.
Very good. Next. Very good. She's going to be a surgeon, Tasha. Little girl, but brave heart. What type of surgeon you going to be?
I'm still not sure. For now,
Neurosurgeon, CBT,
maybe general surgeon.
kitchen. Hello, ligament, right? The medial side, also the ACL and PCL. Okay, so the priorities of this surgery is that in the acute situation, you need to stabilize the medial side first, or lateral side first, or the collateral ligament. So our plan today is to repair the medial side. The tone is from the femoral side. We repair the ligament back to the bone. Okay, and also the next priority is the PCL. Okay, PCL we do arthroscopic reconstruction. Using, I think we use a hamstring today. Yeah, hamstring, the semitendinosus. She's good, she has a very long leg. It's good for us because the ligament will be very long. Yeah, and also maybe we use the opposite side, the hamstring. Okay, also, or you use the peroneus longus, okay, for the reconstruction. Okay, so our plan today is to do MCL repair, ACL reconstruction. No, PCL reconstruction first. You can do stage ACL reconstruction later, okay? Or you can do it today. Yeah. So our plan is to do everything today. but the post-op care is quite crucial because if we do everything, the patient tend to have stiffness after the surgery. Yeah, but it's good for the patient that she don't have to come back again for the second surgery. โอเคนะคะเดี๋ยวคุณหมอพยายามจะทำให้ทุกเส้น